We are starting our first MDT for the Middle East, and we have the open panel for discussion for everyone. Today we have two interesting cases. Really, we have a lot of cases, but we are trying to only gather those interesting cases which need discussion and can take a lot of debate between the different specialty. Today, inshallah, we have two interesting cases, which is called secondary thyroid cancer, and it is really very rare, but simultaneously they present to us, and for your benefit and for the advantage of the patient and more discussion, inshallah, we are going to present the two cases, and we will going to give a brief update, guideline, and approach for these cases. Yes, Dr. Kazan, please start.
Doctor, thank you very much. I'll be proceeding with presenting the cases, inshallah. Our first case, Heman Ali Majid. He's a 46-year-old male presented with an incidental finding of a thyroid nodule. Now, the patient has a history of renal cell carcinoma, and he was operated 1 year and 8 months ago. He also has gout for 10 years, and he's on medication, allopurinol. Okay, this is the biopsy of the previous renal operation. It was radical nephrectomy, right radical nephrectomy, and the histopathology postoperatively came back as clear cell renal cell carcinoma. It was unifocal, grade 2, and with no sarcomatoid features, no lymphovascular invasion, no renal perineal involvement, no suprarenal gland involvement. Pathologically identified as stage 1B. This is a CT scan of the abdomen and pelvis. It was done 4 months after the initial operation, and it came back as negative with no residual or recurrence. A second CT scan done 8 months after the initial operation. In this CT scan, there was an incidental finding of a thyroid nodule, but there is no recurrence or residual tumor for the renal cell carcinoma. We performed the ultrasound of the neck for the thyroid gland, and this is the result. We can see there is a well-defined regular surface, predominantly solid isoechoic nodule of 3 cm by 2 cm by 20 mm in the right mid-lower third of the right lobe, without micro or macro calcification and increased perinodular and intranodular vascularity. It is TR3 by radiological categorization. There is also 2 small nodules, desmoformalin in the left lobe, TR3. Okay. There are a few lymph nodes seen in the right side, group 4. They are pathological by ultrasound, and FNA was taken from them. Okay, the largest one is 15 mm by 5.8 mm. The patient is euthyroid. This is the thyroid investigation. The FNA, this is the FNA that are done. From the right thyroid nodule, the FNA came back as a TP of undetermined significance, Bethesda 3. While the right cervical from group 4 lymph node, which was pathological ultrasound, came back as a benign lymph node cells with no sign of malignancy. Okay. This is the histopathological sections, thyroid nodule cytology, aspirate from thyroid nodule, cellular smear, and this is the rest of the details regarding the histopathological. This is the histopathological section from the lymph node. Right group 4 lymph node, 15.8 by 5.8. It was the size of the lymph node. So in summary, we have a case for a 46-year-old male who underwent radical right nephrectomy 1 year and 8 months ago, presented with an incidental finding of a thyroid nodule. The size of the nodule is 3 cm by 2 cm by 2, TR3. The FNA from it was a TP of undetermined significance, Bethesda 3. We also had a pathological lymph node in the right group 4 by ultrasound. The FNA came back as benign. So kindly give us your opinion regarding further management and what to be done for the patient. Thank you. Continues? This is the first case, inshallah. We'll be presenting the second case and we'll discuss them together, inshallah. The second case, Fatma Mustafa Agawais. She was referral urologist for incidentally finding a nodule in the thyroid gland. Okay. Similarly, she had a renal cell carcinoma and operated about 8 months ago. She underwent partial nephrectomy. Okay. She's diabetic, hypertensive, and has history of ischemic heart disease. No family history of cancer. She's currently on medications for diabetes mellitus, her heart conditions, ischemic heart disease, and hypertension. This is CT scan of the abdomen of pelvis. This was done pre-operatively. You can see there's a mass 5 cm by 5 cm by 3 cm, solid enhancing exophytic mass related to the upper pole of the right kidney. The mass showing central necrosis and calcification, a butene right diaphragmatic cross away from the renal vessels. Overall, the picture goes with neoplastic process, renal cell carcinoma. For tissue biopsy, correlations. No other lymph nodes seen by the CT scan. Another CT scan is done, and conclusion, the result is about similar to the previous one. No extension to the Grotthus fascia. Okay. The patient one underwent right partial nephrectomy, and this was the result of the histopathology. Okay. We have a papillary renal cell carcinoma, grade 2, 4.5 cm in size, unifocal, pushing the tumor borders. There is no hilar fatty tissue invasion. There is no lymphovascular invasion. There is no perirenal fat invasion. And the tumor was staged as T1B. The immunohistochemistry was done for the tumor, and it goes with the it supports the diagnosis of papillary renal cell carcinoma. This is the immunohistochemistry, and as I said, supports the diagnosis. This is the ultrasound postoperatively. Right kidney, there's a 8.5 by 5 cm with upper pole cortical defect. It's size of previous operation. Otherwise, there is no sign of recurrence or a mass. This is similarly and CT scan the abdomen and pelvis with contrast postoperatively. There is thyroid mass causing and having retrosternal extension. It's about 3.5 in the left thyroid nodule. This is the thyroid function of the patient. TSH is 0.9 and the free T4 13.96. The ultrasound of the thyroid gland shows an enlarged left lobe, 70 millim, and it's because there's a well-defined irregular surface, predominantly solid isoechoic nodule of 45 millim by 40 millim by 37 millim in the left mid-third, in the left mid and low third, with microcalcification and increased perinodular and intranodular vascularity. It's a T-RAD 4 category radiologically. Few lymph nodes seen around the gland. Largest is 4.4 millim by 2 millim near the right lobe pole. And few lymph nodes seen in the left lateral group. Largest is 11 millim by 3 millim. None of these lymph nodes have any suspicious features by radiologically. There is also a few small, less than 3 millim nodules in the right lobe of the gland. So we have a single large nodule in the left thyroid lobe and few small, less than 3 millim nodules in the right lobe of the thyroid gland. Fine needle aspiration was done for the large nodule in the left lobe, and it came back as benign follicular nodule Bethesda 2. No sign of malignancy. So this is the peri-patient. We have a 16-year-old female, known case of renal cell, papillary renal cell carcinoma, who underwent operation about 8 months ago. She has multiple comorbidities, hypertension, diabetes mellitus, and ischemic heart disease. Currently, she presented with a large thyroid nodule in the left lobe, about the size of 4.5 cm. And if any came back as Bethesda 2 with no sign of malignancy, though the lesion is radiologically TRAS4. Thank you again, Kani, for your opinion regarding further management for these patients.
Thank you very much, Dr. Karzan, for this nice presentation. Just a brief history of the or the update regarding the secondary thyroid carcinoma. Secondary thyroid carcinoma is a cancer which is occurred in the patient with the already diagnosed or later on diagnosed as another pathology or another cancer than somewhere else in the body. This is secondary thyroid cancer. Try to differentiate between this and the thyroid cancer, which is metastasized to the lung, to the bone, to the liver, to the brain, which is occurring in the MTC, FTC, and the PTC thyroid cancer. And also try to differentiate between the thyroid cancer, which is occurred due to the ray ablation, radioactive iodine ablation, which is causing the side effect and accumulated in the some of the organ, like salivary, like brain, like pharynx, like stomach, like bone, like prostate, like genital organs, which can cause in the breast even, can cause cancer later on in these organs, called second primary carcinoma, which is due to the side effect of the radioactive iodine ablation. Now we are talking about the secondary thyroid cancer. Secondary thyroid cancer is a rare disease, but now it is increasing. The rate is about 1.5 up to about 1.9% of all the thyroid carcinoma. The most common site is the renal cell carcinoma, lung, breast, colonic, skin, genital organ of the female, of the male, bone, sarcoma. All these organs can give metastasis to the thyroid. When it is occur, usually it is occur after the age of 50. But in the last 2 decades, it is increasing in number and the incidence. Even it is can occur below the age of 50. In about 50% of the cases, the patient is well-known cancer and treated as a primary cancer of the renal cell, for example. Later, you discover that there is thyroid cancer. When you are searching for the metastasis, you discover that there is a cancer, another cancer, which is metastasis from the renal cell. In about 34% of the cases, it will be synchronous. During the attack, during the primary cancer, during the dealing with the primary cancer, we discover that there is a thyroid carcinoma as well, which is secondary from the primary one. In 6% of the cases, you discover first the thyroid cancer, you do investigation, you reach the diagnosis that there is a cancer somewhere else. So it is very, very rare. So classical scenario is that you search for the metastasis for the primary cancer and you discover that there is another cancer in the thyroid. The root of the metastasis by the hematogenous. Apart from those with the upper urodigestive cancer like esophagus, like larynx, like trachea, which can give direct invasion to the thyroid. What's wrong with these cancers? First of all, when you have advanced renal cell carcinoma, especially stage 3 and 4, you must exclude metastasis. 1. Second, you must make sure and guarantee that the patient is cured from the primary cancer and you are dealing with the secondary, which is in the thyroid, accordingly. Third, some patients have a predisposition to the cancer, have a family history of the cancer and some genetic defect, which led them to be more prone to the cancer in the thyroid and the renal and in the somewhere else. In consideration regarding these points, you must decide. Now we have two cases of the stage 1 renal cell carcinoma with the two suspicious nodules in the thyroid. What shall we do for these cases? طبعا in our MDT we discuss the point, and really we are waiting for your last decision, inshallah, to be made by you, and later on, inshallah, we'll proceed accordingly. Dr. Kakel, any opinion, please?
السلام عليكم.
عليك السلام ورحمة الله.
شلون باشا إن شاء الله. Thank you for this interesting cases. Actually, secondary thyroid cancer, 70% of cases metastasis from the primary. So should be the pathologist be aware of that and have a solitary metastasis only to the primary side. This is one point. Second point should be systemic scanning to rule out other metastatic site. And still, if you have a solitary metastasis, the treatment is surgery for the thyroid. It is rare to have this, but still you can every now and then cases presented with single focus in the thyroid. Thank you.
So, Dr. Kakel, are you with surgery for the thyroid or not?
If you rule out other metastatic site, it is single site, yes, you go for surgery.
Barakallah.
Dr. Thank you for the intervention. There was CT scan done for the patient in both chest, abdomen, and pelvic, and there is only a single isolated nodule in the thyroid gland, and we do not have any other site suspicious for metastasis. We also have, in both cases, we did FNA for the thyroid nodules. In the first case, it came back as a TPA of undetermined significance, Bethesda 3. And in the second case, it came back as Bethesda 2. Although the sizes are large, so the FNAs could be non-representative. But this is what you are talking about here, is that the FNAs do not give a clue regarding the nodules being a metastasis. So what is your opinion regarding this subject? Thank you.
I think should have repeating the FNA. Because doing surgery for a tumor or metastatic will be different from just a benign nodule, as you know this.
So your opinion is that if it came back a second time, or if it came back as a benign, we proceed with lobectomy?
Yes.
Yes. In both cases?
Yeah.
Okay, thank you very much, Dr. Kakel, and thank you for the audience, and thank you for all the attendees in this meeting, and inshallah we'll meet you in the sorry.
Thank you.
Thank you very much for the committee for the presentation, Dr. Kazan. Regarding the second case, the female, you forgot an important point. She's now in case of hepatitis B. Now in case of hepatitis B, because the ones she presented to me, it was an active disease. We put her on medical management by gastroenterologist until her titer came down to the level that we can perform the surgery. Once we did the surgery, we did laparoscopic partial nephrectomy. As you said, the result came back to be papillary renal cell carcinoma. We usually, 6 months later, we are going to do a CT scan of the chest and abdomen to search for either metastasis or recurrence. Once the result came back, I noticed that she has a thyroid nodule with extension, retrosternal extension. We did referral. Regarding the differential diagnosis for this thyroid, it's either three possibilities: either the primary thyroid cancer, or secondary from the kidney, papillary renal cell carcinoma, or sometimes we have tumor to tumor metastasis. Papillary thyroid cancer may be there and simultaneously with thyroid cancer. Regarding the scanning before surgery for the RCC, renal cell carcinoma, the most common site in the neck for the metastasis now becomes thyroid. In the neck, the organ for metastasis from the renal cell carcinoma is thyroid. While for the scanning, in the guidelines, we don't have any pre-operative for the kidney to scan for the thyroid because it is rare. We have just CT scan of the chest and abdomen to search for any site of metastasis, which are lung, liver, bone, for the primary, for the sites for metastasis. Thank you.
So if there is no comment, we decided to do a lobectomy for the both cases, inshallah, and later on we'll give you the feedback of the histopathology, inshallah. Any comment, please? Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.